thank you for joining us for today's webinar, Damming the Denial River, sponsored by FinThrive. To get us started, I'd like to introduce our speakers for today, Jonathan Wick, Vice President of Health Insights at FinThrive. Jonathan, I'll hand it off to you.
Thank you so much, Tiffany, and welcome everybody. I appreciate you taking time out of your very busy day to talk about a four-letter word I like to call denials. We'll walk through just what I'm seeing in the market, and then, what I see with denials, I think it's important to point out is we've used a river analogy here. We'll certainly talk about uh, other analogies, if you will, but when I see folks working on denials, it seems to be this river that just is undammed. And so Becky, who helps me a lot, came up with this name, and I love it. I've called it a carousel of hell as well, where it just keeps doing circles, and rivers sometimes do that too. And when you're looking at the presentation today and listening, I really want you to think about changing for good. You hear a lot about denial management, which is a term that makes the hair on the back of my neck stand up a little bit. I like the term denial prevention and really damming this river and stopping this flow of leakage or leaked revenue through your workflows to make sure that you're working as efficiently and as expeditiously as possible. Little quiz for you. Does anybody know where this is? You can throw it in the chat or at the end we could guess, but this is a very famous river. I'll give you a hint. It's in Egypt. It is, in fact, the Nile River. But denials are not just a river in Egypt. They are very, very real. I am a dad, so I'm full of dad jokes today. My point is one, I didn't know the Nile or the Nile River is so pretty. It is a very beautiful place and very verdant as you're looking. I also think denials aren't something that's pretty, and it's something that we need to think about as an organization, and they're very, very real. But look through kind of as you're looking at your denials, try to look at them a little bit differently was the point of getting your attention here. They have spiked of late. This is data that we get from Clarivate, a partner of ours that I appreciate. Many of our hospital customers subscribe to them. I did when I was a chief revenue officer as well. They're about 3 times, gang, what they used to be. They spiked pretty markedly about a year and a half ago in 2023, up to 3.5%. These are write-offs. These are not initial denial rates. These are fatal denials. They're starting to come down a little, but they're still hovering around 2%. Those of you that work denials should know that the industry benchmark out there is about 1%, and that's write-off rate. Initial denials are about 10%. We'll walk through that in a minute. But really, if you have more than 1% denials, you're not doing it right. And you are having some issues that are happening at your organization, and there's opportunity in that. We'll talk through some of those solutions. $181 to work them. This number fluctuates all over the place. I usually try to find the worst one. I think that number will come down as we see things like AI and others adapt there. I mentioned the initial denial rate of about 1 in 10 or 11%. Really frustrating or maybe encouraging, depending on if you're a pessimist or optimist on glass full, glass half empty. 82% of these things get overturned. So most of the time, you're right. And I want you to look through that lens today as well. As you're damming the denial river, you're right. The doctor wouldn't have ordered the test that was needed. It probably wouldn't have been performed if it wasn't needed. It's just there's some rule or something that changed that caused it to not get paid or become risk of being not paid. But you were right. The doctor was right. And I would argue the patient were probably right. And when you prove all of those things, which takes an exhaustive amount of time, 82% of the time, and I've even seen that number as high as 90, are there. Many of them are avoidable too. It's just some administrative mistake that came. You're right, but it wasn't submitted the right way. Average write-offs in that 2.5% we saw earlier is about $2 million a year in a mid-size hospital. It's closer to probably 5 to 10 million in a very large health system or IDN. About 7 to 11% of claims are underpaid as well. I'm not going to talk about underpayments today a lot, but they typically go hand in hand. Payers don't pick up the phone and call you and say, hey, Mr. Wick, we underpaid you. We're going to give you more money next month. That doesn't happen. That burden of proof is on the healthcare organization to prove that, just as it is to prove that you didn't need to have that authorization or that pre-cert or that referral or things changed. And typically, hospitals that I talk to, I have the luxury of going around the country a couple times a month and talking to very, very many hospitals, just like yourselves. I find and they find when we start talking about it that there's about $5 to $10 million of opportunity if technology is applied to help prevent and mitigate some of those denial shortfalls that are happening. It's not fair. My mama used to tell me, I'm sure they're going to tell you too, the world is not fair. Payers have a lot more employees, they have a lot more money, they have a lot more patients, they have a lot more technology, they have a lot more attorneys, and they have a lot more power. That doesn't make them right. I used to work for a payer, but certainly most health systems and hospitals that I talk to are outgunned. I mean, we're trying to get that level at FinThrive quite a bit, but I used to work for a payer. We had whole floors of people and tech that just were looking at ways to not pay for something. And that's where those incentives exist. They don't have any urgency to pay it. Their payers have two ways of making money: getting more people on the plan and paying premiums, and having less claims risk or not paying or underpaying a claim. They are mostly for profit. And they have one customer, and that is the shareholder. And that shareholder wants to see the plan grow. Now, to be fair, no one ever talks about the 90+% of claims that payers actually do pay, and they do a pretty good job of doing that. But today we're going to talk about that 5 to 10% that are getting denied initially and how you can help prevent that. And some of that's helping the payer understand what you're doing as well and getting some of those analytics and insights to them to allow you to have the proper documentation to justify your payment. Lots of vulnerabilities exist within what I like to call the claims lifecycle or patient account lifecycle. I'm not going to go through all the globes here, but lack of insight leads to lack of understanding from where you're at from a documentation standpoint. Super important to make sure the clinicians are engaged. We'll talk through solutions later, but they typically are not. Uh, there's some laziness, I'll call it what it is, on behalf of lots of hospitals as well. I used to work for one where we thought the claim was, quote, good enough, and we were sending it over the wall and was hoping that it would get paid, knowing that we probably didn't have the right amount of documentation. My thoughts since working on the technology side have since changed, and I instruct hospitals to hold claims if they're not right because it's a waste of everybody's time. But in all of this, without having access to the insights and data, there really is a partial view of how you're getting paid. We're going to talk a lot today about payer contracts. Everyone seems to whine, for lack of a better word, about denials. You're not going to fix denials. You won't. There's not a way to do that with anything. You're going to have to look at it holistically through an RCM partner, beyond that of your EHR, to really drive change and to prevent them for the long term. And that's a holistic view of those contracts that allow the payer to behave in the way that they are and do not allow you as a provider or a hospital a instrument to combat that or hold them accountable to that. And as such, it's kind of free reign in the wild, wild west in the payer market. The relationship's not getting good. I think if we could get a divorce, we would. It's funny, I don't think hospitals could exist without payers, and payers couldn't exist without hospitals, at least in the healthcare market. This is a study from AHA from a few years ago, but I still love the stats. 95% of hospitals are increasing their staff time. I assume that's still continuing. 84% report the cost of complying with the insurance rules is increasing. Over half of the initial denial rates are prior auth, and we mentioned that 80% earlier. And then it's only getting worse. They say this relationship's getting worse. It's getting so worse that we're having robots fight our wars for us. Providers have not really adopted, artificial intelligence until I'd say the last 5 to 10 years. And it's in back office billing, limited focused use cases for the most part. It's starting to slowly progress into the front end. It started, to be clear, in the middle in kind of coding and charge capture to automate processes there. But payers have had this for some time, and they have optimized it and are using it to their advantage. And people are paying attention, and they're also getting busted. This is a article that the HFMA put together about a year ago, and it said, we've been invaded. Sheldon and I are good buddies out at Houston. It's this battle of the bots right now. Ashraf from KPMG, a physicians group management company, said that, we're essentially having to arm both sides of the house. And I love this from Amy from Corewell. She says that there's been this triple D: downgrades, delays, and denials. And Cigna was the first to kind of get in big trouble about almost 3 years ago here, where they were automatically rejecting claims without even looking at them, even though their contract said that. There was a class action suit for that. United was soon to follow in November, and they had one on Medicare Advantage. Humana, another insurer, and I usually am a big fan of Humana, of all the payers, but they were the latest to be hit with a lawsuit of algorithms. This was December of 2023. And then these knuckleheads, just this last July, Blue Cross of Kansas City, as if they haven't seen these headlines, tried it themselves and got busted as well. And I think the payers are aware of this. It's part of the reason why we're seeing kind of those denials come down, because they're having to go back to what their contract says, peer-to-peer, clinicians looking at the medical documentation as they're looking at the denial and understanding what it is that they're seeing, and actually taking the time to consider all the aspects, not just applying a rule. Now, could you do it faster? Absolutely. I think there's opportunities for AI on both sides, but when you're using it to shortcut, like the payers, they got in some hot water. Now that I've thoroughly depressed you, let's talk about how I'm seeing hospitals fix it in the hospital space. Most folks handle this by committee. And I don't know that that's necessarily wrong. This is a survey that was done by Clarivate. They surveyed 1,100 hospitals, very large sample size. It's about a third of them. And they said that 81% put a denial committee in place. And they get the department heads, they get the CFO. You could put a thumbs up or a chat if you want out there, but I guarantee you all have had a capturing lost revenue or denials committee that tends to meet probably monthly, maybe quarterly, maybe weekly, maybe daily, who knows. But it's ring around the rosy, gang. It is, let's talk about what denied last month and see if we can't fix it. And let's do that again and again and again. And it's exhaustive. It's expensive. Those meetings take a long time. They typically have very little dotted line or straight line accountability. The rules change, so what you came up with before can't keep up, and it becomes very, very tedious. Denials are pervasive, and having a committee and throwing bodies at it is absolutely not the way to fix it. I think you need to have folks look at and analyze what's happening and certainly go upstream to mitigate and prevent those denials. But having a committee trying to prevent them month to month and having it change is the definition of insanity. You're going to do the same thing over and over again and expect a different result. It's your revenue. Automation and AI can really help you protect it. So as we're talking about damming the denial river, you've got to start looking at technology, and you've got to start looking at protecting your revenue and thinking about it as your own checkbook and what automation you have there as you're looking at your credit cards and your household finances and all the fraud and things that are happening there. And imagine if your employer just paid you less next week. You'd be really upset. And some of you may be that upset with the payers. But high opportunities for automation include data entry, understanding the charge reconciliation, pre-adjudication process, these work queues. If you're an Epic shop that's listening, I bet you hate those two words together, work and queue. There's too many of them now, frankly, I think, and they are maybe causing more harm than good. How are you checking your eligibility? I've had slides before in the past. It's really funny. I guarantee you most of your denials are probably that of eligibility, but yet you check eligibility every day. So what the heck? What's going on? Why is this cycle of denials happening if you're having eligibility and running transactions and seeing that and updating your demographics, and yet you still see that as a write-off month end and are looking at it in those committees? How are you following up on your claims, and ultimately is that cash being posted at the right level? 68%, the majority of folks are using a partner to manage their denials and to prevent them. A third are not. And I would argue, I haven't done the math yet, but if you went out there to go look, those ones that are using technology are probably making more headway than those that are not. Other strategies I've seen in terms of just managing payer accountability, I don't even like talking about denials. I just like holding payers accountable to giving me my money. As a hospital, to quote Sheldon Pink, I just want my money. Document. So having analytics that show when, where, how long, and more importantly, outliers. We'll talk about scorecards here in a minute, but hey, payer, you're number 8 in my list of payers of worst. There are 7 payers that pay me better than you do. They pay me on time. They don't have as many denials. There are not as many underpayments. You are the worst. Believe it or not, a payer does not like hearing that. They don't want to be last. And that is super huge to be able to document that across your payer base and understand what it is that they're doing that's different. Having meetings with them, and this is beyond the JOCs, beyond those joint operating committee meetings, but everyone has a rep. I think the relationships with the reps is probably the strongest, but is managed care at the table with you? Are revenue cycle folks and billing folks being involved in the negotiations? Are there provisions that are being flagged as the contract's being negotiated, or 90, 180 days in front of renewal that says, hey, because of this definition of medical necessity or this timetable for changing auth rules, we lose $8 million a year. And so we can do that, but we sure as heck should ask the payer for $8 million more, because we're not going to get the money anyway. Payers pay and chase, gang. They say you get 4 to 5% rate increases. When you look at the yield, what actually comes out on the back end, it's closer to single digit 1 and 2%, because they know that you're going to grow tired of fighting over and over, and they've got more resources to delay, deny, and downgrade. Contract language, super huge. That one's probably the number one tactic. What is the contract that is causing the problem? Collaborate with other businesses and advocate. So I'm starting to see a lot of this right now. Buddy up with your partners. Don't be afraid to sue. I think you get some of the other systems involved. The payers need you just as much as you need them, especially if you don't talk a lot sometimes in highly competitive areas, but if you've got 6 hospitals within 50 square miles of each other and they all go to the payer, that payer is going to listen. It becomes a Walmart principle very quickly, where you're advocating as one. And the associations, I think, HFMA, AHAM, NAHAM for that matter, have some work and opportunity in that area to really advocate as a group for these payment issues, because we're advocating on policy to some extent. We're not advocating on contractual compliance. I talked about scorecards, and then that escalate to lawyers. 1 in 3 gangs pick that, and they are not afraid to turn, because they know that that might be the only thing they can pull. And a payer cannot operate a network with something called adequacy. That's usually a state and federal provision that was in their contract. They have to have what's called network adequacy. And to have that, they got to have you. And if they don't got you, they can't do it. And so if you say, I'm out, I'm tired of not getting paid, the conversation changes. And you have to be able to do that. Yes, it impacts your patients. Yes, it impacts your things. But if you just roll over like a turtle, you're not going to be able to hold them accountable. You've got to look at these strategies and really try to dam the river and move from committee and looking at denials retrospectively to actionable change within your health system, and having the insights through technology and contract management and analytics to allow for that are super huge. Other strategies I've seen work is allowing them access to the EMR. Now, this is scary. And Epic has a payer portal now too, which I think allows for some of this also. But hey, payer, we're going to tell you every time a patient gets admitted, you can go look at the chart yourself. And here's the fun part. We're going to assume they're an inpatient until you tell us they're not. And you're going to pay us that unless you tell us they're not. You flip it. Instead of you having to prove they meet inpatient criteria through Interqual or Milliman. The contract says they have access to their patients, and their UR team looks at it, and they have to say something if they don't feel it meets criteria, and they're the ones on the hook for a timetable of 24 hours or not. Very interesting. Think about that. I've seen some hospitals negotiate a zero goose egg percent increase in their contracts, just rolling the rates and saying you can't have us anymore. Like there's not going to be any us. We're going to be a gold carded organization. Banner and Aetna, really cool to go check them out. Banner is one of our larger customers. Go look at them. Go look at what they're doing with Aetna. Really, really cool. The work they've been doing out there, Elevance and others. Arbitration we talked about. Fee for service with upside risk. I've got a ton of details on these payer strategies. Just in the interest of time, we're going to skip over to other things we've learned. Global EMR access may not be the best idea. So allowing them to see every single one of their members. Believe it or not, I worked for a payer. They will reverse engineer other things to deny you for. So less is more, minimally necessary. That's also a HIPAA term. Watch out if you're going to let them come into your room and look at the data and understand. Prompt pay penalties, making sure those are in place. Medicare Advantage, looking at the payers that are working with you. Most folks hate Medicare Advantage plans, but I will argue there's probably one or two within your network of plans that actually are better than others. Move all the members there and turn the others and work on it that way. Managed Medicaid, another area of volatility. We're going to see with OBA, the One Big Beautiful Bill Act, too, a lot of payer shifting. And so managed Medicaid, I think, is going to have some fallout of about 10% for your organization. And then, what is the termination? Is it worth it? We talked about as well. What does it take to bend this curve? I like talking about the denial curve. I don't think anyone's ever going to have zero denials. But can you get it down? Can you make that 3% 2, that 2% 1, that 1% half? I've seen several organizations that are best practice having a sub 1% denial write-off rate. And that's a goal. They're not going to ever get to zero because it's just the way things are. But what they've done are these three things. They know the rules. They know what those requirements are. They have timing to allow them to change when they change. They've got access to payer bulletins. We can talk about that too with FinThrive and others if we need to, but what they know what the rules are. I used to call the payers all the time and go, hey, I want to follow your rules. I just need to know what the hell they are. Tell me what they are. I'll tell my registrars and my financial clearance teams, and I need 60 to 90 days to do that. You can't tell me that this requires an auth tomorrow. We are an organization that sees 700-800 patients a day. We see it 500,000 in a year. We can't. And some of those were scheduled months ago. So we need time to follow your rules. And if the contract doesn't allow for that, we at least need that. I'm not disagreeing with the rule. I in fact think prior authorizations, I'm going to get a lot of hate mail, but I think prior authorizations and eligibility checks are a good thing. I think that's great. And I think they're needed in our industry for lots of reasons. My point with that is that the rules need to be known. Are your claims clean? So you should be measuring this as an organization. I've got some KPI decks that I'm happy to share if you'd like to see best practice, but a hospital should have high 90% performance in this, 95, 96, 97% clean claim rate. If you do not have that, or worse, don't know what your clean claim rate is or what your definition is, please call me and let's walk through what that looks like and where you're at, because that's a super huge deal. Hospitals are busy, and because of that, they become complacent, and then laziness is the next piece that comes. And I don't like calling health systems and hospitals lazy, but the fact of the matter is it's too easy to submit a dirty claim these days. When they were paper, you saw them, you stopped, you fixed it. Now that you're sending thousands of them out, and there really isn't a mechanism that's checking them, if those edits aren't right, if the documentation is not right, and you're not holding them, and you get impatient, lazy, they ship. If I were a payer too, I'd be like, this is crap, I'm sending it back. So it's really hard to fight and uphold the payer and hold them accountable if your own house is dirty too. So make sure that you're doing the best you are and being the best you can be in looking at your claims, and those things are there. And then finally, you have to get smarter. Payers are super sophisticated. You got to look at AI if you're not looking at it. You got to have it deployed in some areas, got to have some bots, got to have some RPA, got to have some machine learning, some large language models looking at the past and really driving better decisions for you, understanding what claims need to be touched that will result in a payment or yield versus ones that will not. And we'll talk through some of these things in a minute, but you could save a lot of money. We talked about that 3 to 5 million. That's a case study down there that talked about that we certainly could share at FinThrive if you need to see it. Here's some opportunities for denial prevention within the claim life cycle. So remember the globes I showed you before. 5 whys. I'm a big lean guy. 6 Sigma, black belt. You've got to look at those CARC and RARC codes and understand those are the adjustment codes, the remittance adjustment, claim admittance, and the claim admittance reimbursement code. What those codes are, how you're categorizing them, putting them in the right buckets for payers, holding the payers accountable to those codes too, and having the contract say that to make sure that when you get a denial, it's right, not nebulous and vague, right? And you're working on that on the front end, having a flag that says, warning, if you submit this claim, it's 90% of the time going to deny. Predictive denials, right? Or at scheduling, warning, you're scheduling something that requires stuff that you don't got. Stop, or you're going to do it for free. Warning, when the patient shows up, this patient is here. They don't have what they need to get it. Warning at coding, this patient does not have the documentation that's going to support this level of care. You need to stop. Laziness, I'm going to keep coming back to that. It goes through, you don't stop, and then it drives and you're in big trouble. So really got to look at that and be really like uber disciplined and all in on that and really bridge that gap between those financial and clinical revenue cycle. You're going to hear that term a lot there at NAHAM too, that clinical revenue cycle, super important. What is it that needs to happen? Clinical documentation improvements, a super huge area as well, especially on those downgrades. High cost stays and encounters. You're not going to fix everything. Don't try to boil an ocean. If you want to start, like the typical batting order when I'm talking to hospitals is fix your outpatient scheduled stuff first. Start with your high cost imaging studies, high volume MRI, CTs. Bulletproof your authorization process. You cannot get your picture taken if you don't have an auth. It's scheduled. You got to do that. Or you do it for free and the patient pays. But the business, the hospital has to make that decision or you're going to do stuff for free. And yes, there's lots of exceptions to that, but that's the rule, not the exception, right? And then you're going to move to surgery, maybe your endoscopy or your cardiopulmonary unit, but you're going to do that first, like hardwire excellence within your organization through analytics and technology to absolutely know the rules, apply the rule, and stop it when it's not there, and let everybody know. Stop the andon as that process. Standardize that escalation. I loved those phone calls when I was a chief revenue officer. Hey, Jonathan, this is Sally in scheduling. There's an MRI scheduled for tomorrow. It doesn't have an auth. I'd say, okay, let's have a 3-way. Let's call the doc. Let's call the payer. Let's call the patient. And we're going to tell them all the same thing. We have a procedure that's coming that is going to get done for free on our side, and we're going to bill the patient for it. I know nobody wants that. Doctor, you need to get us an auth before the day's out. Patient, if we don't get one, we can either reschedule you or you can pay for it. And payer, keep your ears on because some traffic's coming, and we want to make sure that this is going to you. And it might be an MRI or a CT. We might inject contrast or not, but we're going to cover all our bases so that everyone's there. And you're going to follow that. Make sure those JOCs go well. Let's talk about payment for a minute. This is a maze in China. I can't pronounce Yangcheng. I think that's right. But this is the largest maze in the world, gang. It's in the Yingzhou province in China. You know this is a big maze because it's got 10 bathrooms in it for when you get lost. So it's a super huge maze. This is a picture of it overhead. And I like to think of denials and payment as this maze, right? And you're trying to find your way through the procedure and all of those things, the contract, the CPT, HCPCS, ICD-10 codes that are coming through, the authorizations, all of those things, the changes as it goes. It was scheduled to this, ordered as that, billed as this. You're going through the maze and you're getting lost. AI is the way to get you where you need to be. And here is the way I think you can get through that. We talked about that 10% initial denial rate. and it's costing you that 1 to 3% and that rework. It's this maze of data. You need to change that to the why. We just talked about hardwiring that in your organization from hard or from easy to hard, from your scheduled procedures all the way up to your NICU patients, right, that are having different levels of care. You've got to have this hardwired and apply business logic to reduce that noise and be predictable in what you're doing so that your folks are not wasting their time with fighting these things and knowing ahead of time whether they're going to pay or not. At FinThrive, we're very proud of the data set. We've taken payer data, denial data, and provider data and put it in one dashboard that has a proven ROI to look at that. We've put that in a suite, and it's got a data fabric below and a data lake through Fusion. And it allows for AI and automation and these intelligent agentic AI across our solution sets to drive better outcomes and be predictive and to automate those workflows and to hold those payers accountable as we're working through it. The teams know exactly what to do next. It's built with RCM operators in mind. Revenue cycle leaders, finance directors, and operational teams need that clarity fast. You know on the phone that it takes too long to do these things, and there's too many of them, and you're not going to keep up, and the payer's just going to deny more next tomorrow. So super important to have data-driven insights that show where you're red, where you're green, whether you're trending up or down, like those dashboards on the top, your rejection rate, your clean claim rate that we talked about. That one's horrible, by the way. Your rejected claim count, has that gone up or down? What do those underpayments look like? And then clicking on those and understanding the claim inventory so that you can, next time you have your JOC, and go, hey, do you know you're the number one payer that denies our claims? You're number one. You're the worst one. You deny 40% of our claims. Everybody else is right around 8%. And that's costing us, $700,000 a month. Those are super huge insights to be able to have reactively and then proactively in the prevention arm, just getting out in front of this and really understanding, what is my first denial rate? What is my overturn rate? Where do I need to focus? Is that going up or down? Which payers have claims where they owe me money? What's the denial types by payer? They're in the middle and the bottom. What is my top denial reason? And as you click on coding issue, what codes? And what do they look like? These are all reports that typically have to be run in Epic that might be Slicer Dicer, and they oftentimes aren't linking the remit to the claim, which is a super huge deal to be able to understand that denial and underpayments. And this analyzer, we presented this at HFMA, one of the most fun demos I've ever seen, where hospitals are coming up going, how did you guys get to that? What does that look like? That is so cool. I've never seen data being displayed in this way before to allow me to make decisions really quickly, sharing this with the managed care department, understanding where we could focus, and understanding how the payments are coming in, what's being denied, and being able to track and focus that appeal strategy as well. We talked about RPA and automation. This is a bulleted list, one of my favorite slides, that talks about all the things that humans in your hospitals are doing that a bot could do for you while they're at home sleeping. So very, very important. And then the results are there below in some specific examples. We've got a ton of examples from our bot library. And if you're not using bots, or you feel like you're not using them well, or you don't have them used enough, let us know. But we love bots at FinThrive, and we love them to have FTEs not get replaced, but redeployed to more patient-facing complex things to where they could talk instead of click, right? And then also just drive more cash to your organization through getting that cash to you quicker in a more automated way. Gen AI, you're going to hear a lot about, and I'm not going to go into super huge detail with these examples. You guys will get this deck at NAHAM. But agentic AI, where agents are taking the insights and automating that workflow in an autonomous way, is the future. That's going to be AI 2.0. We've been hearing about AI probably for the last 10, 15 years. Agentic AI is the new black. It is definitely who you want to talk to or ask about if you're exploring AI. How are your agents working? Who's watching the agents? How are the agents being monitored? Are they brittle like RPA was? How do they know where to go? How do they get trained and learned? What are the large language models based on? What are some use cases for those types of things? Coding and billing, as I mentioned, was kind of the pioneer with a lot of this. Really looks at natural language processing. The bill says 3 stents. The SOAP or surgical op note says 2. You're missing 1. That's the best example I can give you of natural language processing. You said they were admitted for pneumonia. The discharge summary doesn't describe that. We're not hitting our HCC triplets or pairs on our multiple comorbidities or complications. Stop that claim. Don't be lazy. Go look at it. Make sure it's documented right. Predictive analytics for denials, my absolute favorite. Identifying those patterns and trends through agents. Have an agent go back through and go, look at all the phone calls. Hopefully they're being recorded and transcribed these days, right? Look at all the denials. Look at all the traffic that's within billing, and by payer, by doctor, by procedure, and by hell, day of the week or hour of the day. You know, you'd be amazed at how these trends come back. But what can that agent do to warn, saying, hey, when these are scheduled on Friday by Dr. Smith with this implant, with this pair, you got a 90% chance of not getting paid. So should that claim hold? You bet your butt it should. It should sit there, or otherwise you're going to play payer tennis, I call it. And it's always 40 love. You're going to be just getting your butt hammered, and they're going to win the match because they have more balls and rackets than you do. They are going to figure out a way. And so it's better to be right and have the analytics and the tech to allow for you to be on at least on somewhat of a level field before you go out. PFX, or patient financial experience. Gen AI really enhancing this. This is the front end stuff. This is probably the newest and sexiest thing, but having chat bots that say, do you have an insurance card? Can I take a picture of it? You know, do you know what your copay is? Do you know where you're going? Have you had a bill before from us? Can you afford your bills? Who is your doctor? Who's your primary care? Have you had cancer before? All of those things are all super cool questions that can get there as they go. Have you changed insurance or jobs? Is this an accident? All of those things. Do you have other coverage? I mean, a lot of really cool things that allow a patient. Is this too long for you to wait for your exam? That type of thing. Does your insurance typically pay your claims? You know, that type of thing. RCM optimization. Comprehensive Gen AI platforms integrate seamlessly, right? And they're there. The end-to-end management, the holistic of it is there. And what I like to talk about with this one is, how does the patient demographics that you captured up front, which is super important for NAHAM, right, relate to the insurance that was picked? I used to walk around my hospital with a coffee can and shake it, and people knew I was coming, and it was full of the cards that had the top 10 initial denials for eligibility. And I'd go, Becky, and she'd dive for the floor, and I'd go, pick a card. And then I'd go into the test system, and I'd say, what insurance is that? And if she was right, I'd buy her a coffee. If she was wrong, I'd say, pick another card. It is super hard to pick the right insurance plan type, right? Gen AI can help with that on the front end and understand, you know, from the Blue Cross Shield plans of the world where that fits. And what I like to say with this optimization within revenue cycles, how does that demographic capture of the insurance card relate to the eligibility transaction of effective coverage and benefits and network for that matter these days? How does that relate to the procedures that are there on the authorizations and payment requirement, on the documentations that's required in coding, to the claim build itself and the edits associated there, to the submission of that claim, to the contract in which it was applied against, to the payment and the cash posting and the denial and appeal if that happened. But if those things are all interrelated, you could see at each point how throughout that patient account life cycle you have or have not addressed the issues that impact the payment of that claim across all of the different access points or failure points, I like to call them. At FinThrive, we've got several use cases where we're applying Gen AI today. This is one for medical necessity, one of my favorites. And the video is going to come out soon on this one. This is just a static image, but you know, there's a claim that got denied. The agent goes out and says, well, has this claim denied before? Across how many patients? How many times have you sent a letter that appealed? What ones won and what things were said in that appeal? How many times did you win? And Did it win because you had this, or do you have a chance of winning? Really, really cool. Even better, I see this evolving to where before the bill goes out or while the account is being scheduled and documented, this medical necessity strategy is building it, saying the strength of the claim, right? Like what is the likelihood of this getting paid as you go forward and assigning risk scores and those types of things. But this is AI that's out there today that is allowing folks to appeal smarter, not harder. Contracts. What paper is being applied to that claim? And is it an old contract or a new contract? Contract management is super important right now. And this is an example of machine learning that'll go out there and look at all the updates, the claim types to make sure that the right edits are loaded for the right date of service on the right paper that applied during that time. Quickly adapts to those details, making sure that those things are happening in real time, and really, really looking at the most accurate, up-to-date prior authorization, payer bulletin information as well to make sure you're applying the rules with your encounters as you go. These are some other examples of deployed AI that we have here at FinThrive. Prior auth, we talked about that, but payer bulletins that load at night that directly integrate into the EMR. Hey, hospital, colonoscopy, that's a bad example. EGDs for Aetna did not require an auth. They do as of 1/1 of 26. Do you have any patients scheduled for 1/1 of 26 or not? Flag all those patients, put them in a work list, get them offed, right? Most of the payer contracts don't have on or after language in them, gang. They don't say if it's scheduled on or after, this rule doesn't apply. It's when the claim goes. It's a data service rule. So lots of denials happen because of calendar year, right? And new paper. Very cool model. Cash flow forecast. We're going to have a ratings call, as a hospital in 90 days. What does my cash look like in 90 days? What's my AR days? What are those things going to calculate as and predict that? And then finally, Insurance Discover. And this is huge. If you're not using Insurance Discover, please call me. But it's a super big deal right now. It's the gold standard in revenue cycle. You've got to have continuous eligibility, I call it, from scheduling all the way to post bill. And is it the right insurance? Are there multiples? Is there secondary? Which one's prime? All of that is super important. And understanding which accounts need to be looked at and that are wrong or validated. It's usually, we'll find 1 to 5% of your revenue that's unknown coverage. And that's a big deal in dollars you can use to have more people in the call center or at your front desk or others. I want to take this probably 5 minutes to talk about RCM TAM, which is something that we've created at FinThrive in partnership with HFMA, another association out there, that helps you understand kind of the footprint of your tech within your industry today. And this model hadn't been around. It's going to celebrate. It's actually just celebrated this month its second birthday. It's in its terrible twos, for lack of a better way of putting it. But really, there hasn't been something that measures how effective revenue cycle is. You have secondary output measures like the number of denials, the cash that you've posted, your collections goals, your bad debt, your charity, your AR days, your AR over 90, your DNFB, so on and so forth. But there hasn't been, hey, what technology do you have? Is it providing value to you? And what does that technology look like? We surveyed 100 systems and did two things. We said, look at all this tech that's out there. Is it of no value, a little bit of value, neutral, high value, or mission critical? And we said of those ones that folks tagged in that 5-point Likert scale of 4 or 5 or mission critical or high value, okay, cool, we're going to keep those in the model. And then we said, do you have it or not? Like, that's great that it's of high value or mission critical, but do you have that in your inventory? And if you don't, that's fine. We'll put it over here as a stage 1. But if there's a lot that don't have it or do have it, it's 60% of hospitals have it, and it's a high value or mission critical piece of tech, and you've got high level performing KPIs, you may be a stage 1, 2, or 3, or 4 hospital. And this is what it looks like. We'll have a QR code here in a minute that'll show you, how to go take the survey. It's free. It's partnered with HFMA. You can click on it whenever you like, and certainly reach out to me if you need to. And what happens is you'll fill out the same survey that these folks did. And you'll say, yeah, I've got eligibility. I've got a claims clearinghouse. I've got analytics with my appeals. I've got a financing thing, whether it exists within Epic or Altera or Meditech or Oracle Cerner or whatever. I've got cash posting that's automated. I've got predictive analytics with denials. I've got ML enabled coding. You kind of pick from that list, and then we send you the report back out, and then you'll get on the horn with me or someone else from FinThrive. It's typically me, and we'll walk through what stage you're in. That I know it's hard to see, but this organization was a stage 4. And you can see kind of that green stripe there, that dark green one that's vertical. Those are all the technologies that they had. And then where you see kind of other colors of boxes, those are ones where they don't have it or are planning to have it or have it in some kind of limited way. And you can see left to right, like how they're doing. And it also shows just like what work streams there in that bottom right corner across intake and patient scheduling, coding, billing, appeals, what technology is in place, that dark green, which ones are not in place, that kind of like regular, just traditional green color, and then which ones are mission critical in that mint color that you might need to look at as an organization. We've done this with about 200 hospitals so far, and we're starting to go back to ones that initially did it, and they're saying, we did not have line of sight as to how the technology was doing, be that within Epic or within these third-party solutions. Most hospitals we talk to have 2 to 3 dozen, 24 to 36 different pieces of tech running the revenue cycle. And as we've talked about denials, there's studies out there. The more tech you have, the more likely you are to have a denial. That's a fact, because there's more places for them to hide and less integration. This organization increased their clean claims rate from 93 to 97.6%. Hee-haw, that's great. And they doubled their point of service collections, gang, and really did a nice job of moving those to an area where patients were understanding and navigating their bills differently. Hospital here in my backyard cut their bad debt in half. And the leader there said, this model allowed me to comprehensively address the critical functions within RCM and allowed me to develop a plan in the short, middle, and long term. And really looked at their cost to collect. 1.1 is phenomenal. The average cost to collect is right around 3% these days. I've got some benchmarks for you if you need to see them. But just really, really cool stuff to have line of sight with that. I'm going to finish up here, and then we'll open it up for questions with Tiffany in just a second. But I love this from Dustin from class. This is a great quote. He says, the goal is not to replace people. And I think you hear that a lot as you're talking about tech and especially with denials and those things. It's to upskill them, gang, and control the RCM to make sure that you're getting analytical, and those data sets we've talked about are way too large for traditional body throwing committee work. You've got to automate them like number 2 talks about. There's a need for it. It'll offset a lot of those challenges. And most RCMs are legacy that I see. They're relying on tech that's good enough, and they aren't really trying to prevent denials. They're just trying to keep the plate spinning, and they're moving the stick to keep denials flat instead of making them go away, right? Which is a super huge difference. There's more denial resources there on that QR code. You can click on that to go check them out. You're going to get this deck as well. We've got about 10 minutes left. I'll leave that up for a minute, and then Tiffany, if there's any questions in the Q&A or others, it looks like there's one in there. I see one on gold carding, so I can answer that one from Nicole. But then if there's others, feel free to type them into the chat or the Q&A, and then Tiffany and I will walk through those as we work through the questions here. And again, you'll get a copy of this deck. The first question I got is, what 2 payers are working towards gold carding? There weren't 2 payers there, Nicole. That's a thing that payers will do. And you should ask your payers about gold carding programs. I headed up a gold carding program when I was working at a payer. And what it is it affords I don't like the name, but it affords a credit limit, for lack of a better word, for you to do procedures without an authorization. And that credit limit is as long as you continue to provide good documentation and don't have big changes in demographics and those types of things. But basically, how a gold carding program would work is, hey, doctor's office, it's typically there, not at the hospital level, so don't get too excited. But hey, orthopedic office, you've submitted 900 procedures over the last year, 890 of those were approved. It doesn't make any sense for you to ask and for us to say yes that many times. You don't have to ask anymore. You're now gold carded. I've seen that happen at clinics. I haven't seen it at acute facilities before, but if you are following all of those payer rules and you're of the ones that you do, they get billed that way and there's not any further debate, that's a mechanism for you to save yourselves and the payer quite a bit of time by just being on a list as a gold carded organization. I'd love to see it at the hospital level. I think it's possible if you have some of the data and insights that we've talked about. If I was a payer and I put my hat on and a hospital came to me and said, hey, we're wasting each other's time. I do 600,000 procedures a year and about 40,000 of them are with you. And of those 40,000, 10,000 require an auth. And of those 10,000, 8,500 of those times I ask, you say yes, and we go. As long as I stay below 10,000 procedures and they don't change in terms of the mix, that's that gold carding part, right? Can we just take the auths away? It's kind of a cool thing.
Yeah, Jonathan, I think we have a few questions.
Okay, cool. Let's get to them.
So how do payer AI tools differ from provider side AI, and how can we ensure we're not at a disadvantage?
Yeah, so know that a pair is going to be more sophisticated. We talked about that earlier. So they're looking at much larger data sets, and that's apparent. So a lot of people, don't fully understand how the payer works, but you got to think, gang, they're seeing not only your claims, but claims from probably 100 to 1,000 other entities, right? And they're comparing the differing levels of documentation, the price, the codes, the the patient demographics, all of those things to really build algorithms to say, hey, we should pay this and deny that or delay this. And it's all AI driven, and it probably has been for the last 2 decades. So they are way ahead of the game. And their tools really are looking at best practices or evidence-based care, it's called, like it or not. They are managed care companies. People usually don't call payers that, but that's what they are, and they are there to manage care. And so through managing care, they're going to look at utilization review, which is a fancy word for I'm going to check on what you're doing and see if you are doing things that aren't wasteful and not covered. And if they are wasteful and not covered, I'm not going to pay for them. And not covered means you didn't give me all the information I wanted. You knew I required an auth. I told you that if you changed the procedure, you had to re-auth it. You didn't care. You sent it, or you didn't know. So their rules are much different than the provider. How do you keep pace? I think was the question. You won't. Is a short answer, but you could start getting ahead of that with some of the predictive things we talked about. So, of the payers, who denies the most, and why do they deny, and what levels of documentation do I need to have? A great example is denying for medical record requests, or ADRs even, advanced documentation requests, right? If you know that those are happening, get a bot that goes out there, logs into the HIM or medical records, pulls the SOAP note, the H&P, the discharge summary, anything else from the EMR you want, attach it with a written letter to the claim, send that claim with those attachments to the payer, and do that overnight instead of having a person logging into there, and do that for payers that deny for medical records or request medical records all the time. And then instead of having to go get them, when they tell you it's a denial, because they're still going to do that, you can just answer back automatically with your own AI that says, I gave it to you. Go check. It's already there. We don't do enough of that. I think that's one short example of how to keep. There's a tons of others if folks have questions on that, on ways you can help the payer help you, and also how you can hold that payer accountable through AI to not have denials. But just let me know and we'll walk through some of those use cases. We can go to the next one, Tiffany.
What are some quick wins for automation in denial prevention that don't require a full platform overhaul?
Yeah, so contract management is probably the shortest putt you should do. And I think if you're on Epic, you probably have it. but it's not modeling for you, at least not in a sophisticated way. It's the librarian, I like to call it. It's checking books in and out in terms of the contracts as they come up for renewal and applying the new adjudication and loading that logic in a periodic, no pun intended, fashion as you go. You need to absolutely understand the contracts at the provision level, and have those be modeled out both in terms of your yield and your payment, but also in terms of your underpayments and your denials. Another short put is something called DUA, which is a DUA, which is our denials and underpayments analyzer. And there you'll see lots of these analyzers out there. I'm really excited about this one. I think it's important because it holistically looks at the claim inventory and really starts to drive really actionable decisions for you that those committees that we talked about take months to uncover. And it's going to show you at payer, code, provider, service line level, RARC, CARC code, CPT, HCPC, ICD-10, what needs to change in terms of your workflow, and then also what in the contract has some level of opportunity. It may not bring the provision up, but you'll know that it's this plan, and then that paper may require more inspection to get the payment you inspect. Our CEO says this a lot, Amit. Inspect what you expect, right? It's very important for us to understand what is the level of expected payment and inspect the contract against that to understand what's happening. And the combination, I think, of contract management and denials and underpayments analyzer, think of the analyzer as a radar dish, and then the contract modeler is the torpedo, right? And those that's probably the best analogy I could give you. But those are two things I think that would help there, Tiffany, for that one.
Thanks, Jonathan. So I think we have one more question.
Cool.
So what KPIs should we track to measure the success of denial prevention initiatives?
Yeah. You absolutely should track initial denial rate. So that's different than clean claim. But what percent of your claims are denying first pass, and then from that, you should track which ones ultimately get written off as a percent of total NPR. Now I've got KPI documents that show that, but if you're above 8-9% on your initial denial rate, you're doing worse than half of the hospitals in the country. Okay, so just know that. So you want to have an initial denial rate that's less than 10%, because that's average, and you all are smart. You're on a webinar. You're better than average. And then on the fatal denial, or the write-off rate as a percent of NPR, your net patient revenue, or NPSR, net patient service revenue, you want that number in very, very low single digits, ideally 1 to 2%. 1% I rarely see. And below that, I hardly ever see, if at all. 2 to 3% is fairly common. Average is around 3 to 4. So, just depending on where you're at, I would track those two first, initial and write-off rate. And then clean claim falls right behind that. You want to have a A on your report card for clean claims. You want that number to be in the high 90s. And then I would start tracking AR over 90. Your percentage there, you want that to be less than 1 in 4 of your claims inventory, so less than 25%, and drive that as you go forward. Those are the big three. I've got a bunch of KPI decks I can send whoever's asking that. We'll figure it out as we move forward.
Thanks, Jonathan, and thank you for a great presentation today.
You bet.
In closing, we would like to give another thank you to our sponsor, FinThrive, to our presenters for sharing their time and expertise with us, and to our attendees for your participation today. Have a great day.
Thank you.